The next question usually is, what do you expect to see on an X-ray?
The classical feature that you find on the X-ray is delay in the maturation, or before that an appearance of the bony nucleus of the capitofemoral epiphysis. Let's say delay in maturation. Appearance, very early stage, very early stage, but there is a delay in maturation of the bony nucleus of the epiphysis. That means the epiphysis to start with will be smaller in size. That is why you find widening of the joint space. So widening of the joint space you find in the initial stages because of delay in the maturation of the bony nucleus of the epiphysis. So it all cartilage, so you cannot appreciate that. Cartilage is not appreciable in the X-rays. And then depending on how the disease progresses and how much of the epiphysis is involved, there could be lateral subluxation. That means when the lateral subluxation takes place, there will be the center edge angle will become more than 20 degrees. And then as it goes on, involvement becomes more than 50%. Then you start getting involvement of the femoral head with flattening. There is loss of sphericity with subchondral fractures. That means there is subchondral fragmentation, and there would be increased width of the physis, width of the physis, increased width of the physis, not the epiphysis, the physeal plate. The physeal plate, the increased width will be noticed, and there could be multiple cystic areas. They are in the advanced stage. There could be calcification in the lateral part of the physis, in the subcutaneous, in the soft tissue region. That itself indicates that the head is coming out. The head is not within the sternum. And there is also broadening, metaphyseal neck broadening or broadening. And then the neck may get shortened. Greater trochanter is getting hooked up and getting proximally, developing much more than the femoral head and neck. So trochanter is developing, so it gives you a Coxa-Vara effect, as the head is and the neck is not developing to that extent. So this will all depends upon the stage of the disease. The spectrum of the disease is very wide. So you may find decreased neck shaft angle. The growth plate, that is the physis, may become convex. Overgrowth of the greater trochanter and irregularity in the growth plate, widening, metaphyseal rarefication, resulting into some cystic changes. And once it has fused, and towards the end stage, when it is fused when the epiphyseal plate gets fused, then in the older children, that is beyond 12-13 years of age, what you get is a so-called overhanging of the posterior part of the head of the femur. that is mushroomy, and the head becoming spheroidal, cylindrical, then what you get is an overhanging, what we call as a rope side, which is nothing but a sclerosed part of the overhanged femoral head, which is giving a sign onto the metaphyseal region in the neck. Before that, you can also get in head-in-head appearance when you find that there is a bony nucleus right in the center, and over it again there is a sclerosed area. So that gives you a head-in-head appearance. In most of the cases, emphasizing again on the age of the patient, that is below 10 years or 9 years of age, the acetabulum is comparatively well preserved. Acetabulum is non-involved. But in older children, you see, there is a phenomenon known as biological plasticity. Either the head remains contained in the acetabulum, but when the head is not remaining contained in the acetabulum, then in the further course of the disease, as the head is becoming cylindrical, it forms a cylinder shape. That means, to start with, if it is from the center of the head, in the acetabulum, if it is hardly 2 millimeter out, then most of the time it's okay. But if it goes more than that, then it absolutely attains a cylindrical shape. And acetabulum also, as the femoral head moves into the acetabulum also start taking the same shape. So it becomes more horizontal, more widened to contain that cylinder. So what you find is changes in the acetabulum according to the function that is taking place of the femoral head into the acetabulum. So giving rise to a cylindrical femoral head and almost flattened
acetabulum
and horizontalized acetabulum. So resulting into a incongruous congruity, because then some amount of fragmentation, irregularity takes place on the femoral head. So that results in incongruous congruity. Earlier to that, when it is just less than 2 millimeter, then what happens is the head remains congruous in the incongruosity. So this is congruous incongruity, and then finally resulting into a incongruity congruous. So it all depends upon the advancement of the disease and the age of the patient when he is presenting to you.
So remember, on X-ray there can be a spectrum of presentations. So it all depends upon the stage at which the patient has presented to you. So early stages would be a different spectrum, maintained acetabulum, and later stages the acetabulum may also be affected. So you have to remember all these stages and the spectrum.
However, whenever you see we are distinguishing between heel tuberculosis and in early stage which has been treated, and the heel lesion and what you call as remodeling taking place in the Perthes disease, in early age group, that is up to 9 to 10 years, acetabulum remains relatively well preserved, while in tuberculosis there is a involvement of the acetabulum as well as the femoral head. So that results in wandering acetabulum. So one of the distinguishing feature is in the early stages of Perthes disease and in early age group, the acetabulum remains well preserved. However, it is not true in later age, that is beyond 12 years of age group.
So remember on X-ray, acetabulum involvement is important differentiating feature between early Perthes and a tuberculosis of it. And tuberculosis will be early involvement of the acetabulum also.